Yeah. Okay. We're recording. So, who has joined us?
Hi, Rick. This is Sherry. I'm taking notes for John tonight.
Okay. How are you, Sherry?
Great, thank you.
Okay. And so let me just put you in. And who else has joined us?
My name is Sylvester Mann.
Hello, Sylvester. How are you?
I'm doing fine, and I hope everybody else is doing good.
I'm sure they are. I'm sure they are. How was your Thanksgiving?
Mine was very good. I went to Sacramento and spent some time with relatives.
Oh, good. Okay. 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 So I think I may have got 1 and 2 mixed up here, so I may have to switch this back across. We don't have any of our regulars today. I wonder where they all are.
Yeah, that's interesting.
It is interesting. It is interesting. It's fine because I it'd be good if we had a slower if we had a slower day for a change. Last week I looked for new people and we had 3 new people, and then we don't have time for anything else, which
Right.
Which is
got a little hectic for you.
Yeah, it does. It can be more than a little crazy. So let me see here. I just want to bring up. I was just over talking to my urologist today for my annual appointment, and I said to him, "Oh yeah, we always have between 13 and 20 people," which we do. I can't remember the last time we have not, but maybe tonight this could be it.
Well, I think your Monday call gets more calls usually.
That's a good point. I'm not sure. Sometimes, but sometimes this Tuesday is. Oh, here comes Bill Franklin. So, hello, Bill.
It's possible, Rick, that 6 o'clock is too early. I mean, for people who are still working and whatever, fighting traffic, getting home.
Yeah, I know. I mean, it was originally, there were a couple of people, Dominic and Bill Burhans and a couple of others, and Tom Van Zandt were the ones that wanted us to make it earlier.
Right.
So we tried, and we could always go back to a little bit later, but we can ask. We can ask people how they feel about it. We're picking up speed slowly. So Bill's still not turned on, and who just joined us there?
Bill Franklin just webbed in.
Hello, Bill Franklin. And someone joined us on the telephone. Who joined us on the telephone?
Dan Schulist.
Oh, hello, Dan. How are you?
Hello.
How do you just help me out? How do you spell your last name?
SCH.
Yep.
UL.
Yep.
IST.
Dan Schulist. Okay. Well, welcome. Welcome. We were just saying that this is kind of a slow day. Normally we normally have about 10 to 12 people by 5 after, but today we're pretty slow. Okay. So let me make a note, and we'll get underway, and we'll see who else joins us a little bit later. Just looking for some clean sheet of paper here. Okay. So, all right. So let's see. So we've got Jake, we've got Bill Franklin, Dan Schulist, Sylvester, Sherry Streslek, and 1, 2, 3, 4, 5. Okay. So right now, this is who I see on the call, and just let me know if I've missed anybody. I've got Jake, Bill Franklin, Dan Schulist, Sylvester, and Sherry. Is there anybody else?
Rick, this is John. I was like, I'll be in and out of but I'm around.
Oh, okay. All right.
Okay.
I wasn't sure if you were there, if you just had your wife taking notes, or if you were there too. So we got both of you. All right.
I was just the note taker, so I'm proud of him for showing up.
Well, yeah, it's very good. I'm glad that we've gotten him back. That's excellent. Okay, so let me just run down. Actually, I'm not going to run down. I'm gonna kick off with Dan Schulist, because Dan, I believe this is the first time that you've joined us. Is that right?
Yep.
You're very welcome too.
Welcome,
Thank you.
And
Thank you.
this is, as I said, it's a small group. I mean, I can't remember the last time we had less than probably 12 people. So this is actually a luxury for me, because it makes it a lot easier to moderate a small group. As I was saying, I don't know if you heard, we had 20 people on last Monday, and 3 new people, and so it was really, really busy.
Oh wow.
So this is quite a pleasure. What we normally do is we give people that are new priority to talk about their situation, and give us a little bit of background on their disease, demographics, and where they are in this journey, and then if they've got any particular issues, then we raise the issues, we focus on them, and we see if we can help you. So if you're comfortable doing that, start off with just telling us a little bit about yourself, your age, where you live, and where you're treated, and a little bit about where you are with your disease.
All right, sure. I'll try not to go into too much detail, I guess, but I'm 51 years old. I'm live in the Midwest, in Wisconsin in particular, Milwaukee area.
Mm-hmm.
I was diagnosed in May with a PSA of 120. Biopsy was all 12 cores were positive, 11 8s and 1 9 on the Gleason. Had the scans done, showed lymph node involvement, 5 or 6 lymph nodes. One of them is outside of the pelvic area. And I did initially test positive for a bone met on my femur,
Mm-hmm.
but had since had it biopsied at Mayo, and they said it was negative.
Mm-hmm.
So I am currently was being treated by a local doctor in Milwaukee, since gone to Mayo Clinic
Mm-hmm.
and have been treated there since. And currently I'm scheduled for RP and lymph node removal on January 27th.
Okay. Okay. Is that going to be
I'm also-
robotic? Is that going to be robotic, or are
No.
they going to do open?
Open.
Okay. Okay.
I am also currently investigating CyberKnife as a potential treatment.
Mm-hmm. Mm-hmm. Mm-hmm.
My PSA is, last time checked, was beginning of November. It was down to 0.1. I started on 30 days of Firmagon, and then was on Lupron for 45 days, and have been on Casedex since.
Mm-hmm. 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 Sorry, I don't know if you can. There's a big load going down my narrow street, so if you can hear people yelling, they're trying to move the cars. I'm sorry about that. If it's
I hear you fine.
yeah, good.
I thought someone was playing a video game.
No, it's it's a big wide load. This is the second one. I don't know what they're building up there or something. So, what was your PSA at diagnosis?
It was 120.
Oh, that's right. You said that. That's right. So you responded well to is it Lupron you're on? Is that what they put you on?
Yeah, they initially put me on Firmagon
Oh, right.
because
Okay.
Lupron apparently has a spike.
Yep.
So they put me on Firmagon for 30 days. I went down to 9.5
Right.
after 30 days. Then 45 days of Lupron, I was down to 1.5.
Right.
And then it's probably another, let's see, mid-August, September, October. 2.5 months later, I was 0.1.
Okay. Okay. So I'm sorry I missed it because that big truck was going by. But did you say that you did take some Casedex at some point, some bicalutamide?
Yeah, I've been on Casedex since mid-August.
Hmm. And was that Mayo that put you on Casedex, or was that your local urologist?
No, that was Mayo.
Okay. Okay. Who's driving the bus at Mayo for you?
Dr. Carnes.
Okay. 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 And I'm just curious, what made you decide on Mayo versus, say, University of Wisconsin in Madison?
You know, I didn't see that they were that involved with prostate cancer, quite honestly, in the research I had done there. And just Mayo has, you know, in the Midwest has a very strong reputation.
Right. Well, John Streslek can fill you in a little bit about Madison, and they do actually have a really good prostate cancer group, and they recently
Oh, really?
they recently became an NCCN hospital. Go ahead, Sherry.
Yeah, I forgot the name of the guy we're speaking to, but Rick,
Dan.
I was going to ask why he went to Mayo rather than a local place. John just stepped away, but we see Glenn Liu at University of Wisconsin. He's been with John for 15 years, and I mean 24/7 he's available to us. Has an excellent reputation, I think. And John can say more of that if you were to look. I'm glad you gave a compliment to the UW because can't compare it. We haven't gone anywhere else. But when I heard Mayo, my ears kind of thought maybe we should go there for an opinion. I know Glenn Liu is one of the people went to UW and then MD Anderson, and the people at MD Anderson, Glenn Liu is as good as you can get. Just a thought. It's good.
Yeah,
How do
I
you
mean,
spell that?
Lou.
IU is his last name. And the head of the prostate cancer, and I forgot his name right now. I wish John were here. He stepped out. He started the prostate cancer unit at UW. He was just recruited by MD Anderson, so he has left. But there's a great staff. We're getting some Cleveland Clinic doctors. That's enough. But John can give you more information if you. It was very important to him that he connected with somebody that he could talk to, and this is the guy we found.
Huh. Yeah, I'd be interested to know more about that because that would be a lot closer to me.
Well,
I'd definitely consider going there.
I'm sure John will be back during the call, and we'll bring him on. And Sherry, let us know when John gets back close to the phone, and then we'll talk. But here's the first of all, I want to say the good things, and the good things are that it's a terrific sign that you responded so well to the hormone therapy. I mean, it's you know, there are people that don't. Their PSA just doesn't come down anywhere near as quickly as yours, Dan. And the fact that you're now at a negligible amount, you know, less than 0.1, is a good prognosis. The big issue, I think, for somebody in your situation is to really determine what the value of surgery is, because you're almost certainly going to have to have radiation. If there's lymphatic involvement, I mean, did they stage you as T3 or T4?
T4.
T4. So, you know, there are a lot of places, Mayo is not one of them, but there are a lot of places that don't believe in surgery or radiation for people with stage 4 disease, or did not. That's changing quite a bit.
Right.
Now, if you have fairly limited metastasis like you do, and even if you have more metastasis, there are many hospitals that are willing now to debulk, what they call debulk the tumor, but that's something that Mayo has always been known for and always been eager to do. The likelihood is that if you're a suitable candidate for surgery, as they seem to think you are, you have to follow that up with IMRT. And the question, and you're probably going to have to stay on hormone therapy for a couple of years.
Right.
Could I just ask anybody that's, if you could, other than Dan right now, if you could mute, because we're getting some background noise, it would just help us a little bit, and I'll give you time when we call you back on. So one of our regular guys who is not on with us tonight is a fellow called Steve Bornstein, Dr. Steve. He's a retired OBGYN who was diagnosed with a PSA of 1,000 about a year ago, and he was a Kaiser Permanente doctor, and he had a very significant position at Kaiser, and he has actually convinced Kaiser recently to do SBRT on his tumor, on his primary tumor on the prostate, which he's gone through, which is sort of what you're talking about, because you obviously have a lot of cancer in the prostate. You know, unfortunately, he may join us. He may join us on a delayed basis, but if not, I can definitely connect you to him.
Okay.
But the bottom line is that it's not clear, and there's really no studies, whether if you're going to do surgery, if you're going to do radiation and hormone therapy, how much the added surgery contributes. Now, I tried to find this out when I was diagnosed. You know, I was fortunate. I had a T3 diagnosis, and I was considering doing surgery. But when I ran the nomograms, because there was nothing that was seen outside the prostate, the likelihood was that 70% that I need radiation and hormone therapy, and I personally decided not to do the surgery and just to do radiation and hormone therapy. And you know, one of the things that you might want to do here, particularly since you've just learned about the existence of you know, a good department at Madison, is to get a second opinion from somebody like Dr. Liu as to whether they think that the added benefit of surgery versus just the radiation and the hormone therapy.
Right. Yeah, I don't know. I guess that's interesting. I thought most of what I had read showed there was some benefit to the surgery in removing the prostate. And I was actually hoping to maybe avoid radiation by going this route, because the plan is, if they, you know, best case you go through the surgery and you come back undetectable, there would just be hormone treatment. I know that's a bit of a long shot, but I guess it's not out of the realm of possibilities.
Well, do they plan on taking every lymph node, or are they just going to take lymph nodes that they see as being contaminated?
He said they would take 20 to 30.
So they probably
see 5 or 6.
Yeah, so
5 or 6 on the
yeah,
skin.
so they're looking at cleaning out the lymph nodes. You know, I don't know. The problem is this, that when this disease metastasizes, and particularly when you're looking at the sort of micrometastasis that precedes the lymph nodes, you really don't know where it is. And you know, it may well be that they take all the lymph nodes, but there may be a small amount of yeah, you need 2 billion cells plus 2.5 billion cells to be able to see the cancer on most of these scans. And if you don't have that volume, you know, it depends on the scan, of course, and the newer technology, I think they can see less, but it really depends on the scan. So the thing is that when you get radiation across your whole pelvic girdle, it kind of nails everything. You know, then it's not as focused as surgery. And you know, we don't give medical advice on this call, but we're happy to give some opinions as to what we ourselves would do, and people will tell you what they have done. And if it were me and I had that sort of diagnosis, I sure would want to get my whole pelvic girdle radiated if I was a prospect for surgery. I'd also want to get myself radiated. But that's why you know, I think it's a good idea to look at, maybe you're talking about SBRT. I think you'd also be a candidate for high-dose brachytherapy. Are you familiar with that?
Yeah. Yep. I've done a little bit of research on that.
You know, I think you'd be a good candidate for high-dose brachytherapy, which is now in most places a single treatment. It used to be, until a couple of years ago, it was 2 treatments. I don't know what UW how UW gives it, but most places now are going to a single treatment. And you know, 25 or 30 IMRT and 2 or 3 years of probably minimum 18 months of hormone therapy. I mean, that's a different approach to doing the surgery, and or you do the surgery as well. If you have anything on the added benefit of surgery, I'd love to see it. I mean, the best estimate that I got was from the chief of urology at UCSF, who felt that the added benefit was around 3 or 4% for somebody with T3 disease. With T4 disease, it's kind of a new ball game. Let me open this up. We've got some, I see that Paul Hobson and Paul Frieda have both joined us, both of whom face similar decisions. Let me just recap for their benefit, because they may not have been on. This is the first time Dan joined us. He's 51, lives in the Milwaukee area, being treated at Mayo. He had 12, yeah.
Before you go on, I don't think Paul or Paul are actually on. I don't see any kind of indicate Paul's on it.
Paul's on now.
Paul Hobson's definitely on.
Yeah.
Okay, now they're here. Okay.
Yeah, they're both on. So let me just finish. So Dan has 12 positive cores. 11 were Gleason 8s, 1 was a Gleason 9. There was clear lymph node involvement in 4 or 5 lymph nodes and 1 lymph node out beyond the pelvic girdle. There was a possibility of a bone met, but it was biopsied and it seemed to be clear. And right now he's at Mayo, and or he's with Mayo Clinic, and he's thinking about doing surgery at the end of January, and we're just talking about some other options and what might be available for him at University of Wisconsin in Madison, which is a recent NCCN hospital. Guys, what would you, let me open it up and see what you have to say. No? Paul Hobson?
I've had prostate removed. I've also had stereotactic radiation to Mets. I think the situation on removal of prostate where you've got metastatic cancer, there's just no hard scientific evidence as to what the effect is. There are some sort of studies that suggest there might be benefit in it, but the evidence isn't there. I suppose, though, looking at a lot of people suggest that you try and, the whack-a-mole approach, that you try and get as much as you can as early as you can, but just bearing in mind you've got the micro-mets there and it may not be successful. But, there's quite a common view, if you get rid of it as much as you can as early as you can, that's beneficial.
Mm-hmm. Yeah. Paul Frieda, you want to add anything? Because I know that this was an issue that you wrestled with significantly.
Yeah, I came in a little late, but I think I gather what's going on. The question of whether to do radiation or not. In my case, I had good reason.
The question is whether to do surgery or not with metastasized disease.
Well, in general, it's probably not going to increase your longevity, or if it does, it will be a small amount, because cancers grow exponentially. And but on the other hand, if you've got a very large prostate and there's a large amount of cancer in there, it's understandable that one can get that bulk out of your body. So I don't know how much of the tumor is in your prostate right now. So it's hard for me to make a judgment. But once you're metastasized, unless you have a good reason, probably not going to help that much to do the surgery, especially considering the side effects of surgery and also the quality of the surgeon that you have access to. So, you know.
Right. What about Bill Franklin? Because Bill, you sort of looked at this a little bit too.
Yeah, at first I did, but mine wasn't quite as aggressive as what Dan described, and I went fairly quickly with the radical prostatectomy, but mine was you know, already the margins, and after surgery my PSA started rising again, so I had to do the radical prostatectomy and radiation as an adjuvant treatment, and I was on the Lupron the whole time.
Right. Sherry, is John back with us yet, or is he still out?
Go get him. I'll go get him.
You'll go get him, okay. Oh, look, I see an Eric Bookbinder with his hair tied back. Oh my goodness, it's hard to recognize him. Yes. For those of you who are on GoToMeeting, we have video captions. If you want to be seen, you can be seen. And Eric has just shown up, and instead of having his afro, he's very well groomed today. So
I can't see Eric. I can't see Eric. I wonder why.
Oh, you can't see Eric?
I can't see you either.
Oh, I don't know. We can see each other. I don't know why.
Okay, maybe my connection's a little slow and it's adapting. I don't know.
There you go. And now we're about to get a view of Paul Hobson in Australia as well. Yeah, I should have mentioned to you, Dan, that Paul calls in from the other side of the world.
Okay.
He assures us he's not standing on his head, but I'm not so certain. So, what I really want to do is we'll get John Streslek in here, because I really think that, I mean, we're really lucky that it just happens that we've got John available to help you, because he is.
Rick, I'm back.
Yeah, you're there.
Yeah.
So John,
Yep.
Did you hear Dan's situation or not?
No.
Okay, so we'll recap it again very briefly for you, and then I think that your input is going to be very, very important for him. Dan lives in Milwaukee. He's 51. Right. He was diagnosed in May of this past year with 12 positive cores out of 12. 11 were Gleason 8, one was Gleason 9. And his PSA was about at 120. He was staged at T4. And he has 5 or 6 lymph nodes with at least one outside the pelvic area that are contaminated. There was a possible sign of a bone met, but it was biopsied and it was negative. And he's chosen to go initially to Mayo and see Dr. Carnes, only because he didn't feel that there was a good prostate cancer hospital in the area. And I said to him, well, you know, University of Wisconsin-Madison has an excellent department. They're a recent NCCN hospital, so they participate in all the trials. They're doing some very good prostate cancer research right now. I know they're working with Chuck Ryan on a couple of trials, Chuck Ryan at UCSF on a couple of trials. And the question at hand is that, of course, Mayo being Mayo, they want to do lymphadenectomies, remove all of the lymph nodes and remove the prostate. Dan's thinking, well, you know, what are the other alternatives? Should I look at radiation? Should I look at something focused just on the prostate, or the prostate plus the whole pelvic girdle? And, you know, I'd like you maybe to talk a little bit to Dan about what he might expect to find and who he might want to see at Madison, because as Dan already said, it's a heck of a lot closer.
Yeah, it sure is. It's hard to separate out the university. When I first started my involvement with them 15 years ago, a fellow named George Wilding was there, who essentially started the prostate cancer clinic. So what I inherited because of prostate cancer was a whole team of people involved in prostate cancer. George Wilding was the chairman of the department, but a fellow named Douglas McNeil was there, who has been investigating immunotherapy in particular. And Gwen Liu, a medical oncologist, was also attached to the program. Recently, they brought on board a young man named Chris Christiakopoulos, who I think came from the Cleveland Clinic. And I've had some interaction with him that I was impressed by as well. One of the things that I've run into, going back specifically to my involvement with Glenn Liu, is that although you may be teamed, as a lot of centers do, they team you as a patient, he's always been what I've referred to as my go-to guy. I mean, he's always helped keep me centered, focused. He hasn't over-recommended any particular approach. But the best thing is that he's included me in just about every decision all the way through as an equal to him. Now, it's unusual. Not all the guys in that particular team approach me the same way. It just happens for me. Glenn and I hit it off as almost a partnership in addressing my prostate cancer. He's been available. He's been on top of all of the national research. As you probably heard me last week, I don't know if I could have possibly covered it all, but I've had just about every form of therapy available. Obviously, there's more left in terms of clinical trials. Rick, you mentioned the possibility of Provenge. That's something I'll be looking into. But all the way along, it was initially the gold standard back 15 years ago was, of course, radical prostatectomy, and that's something we made a quick decision to have. But then after that, it became the focal radiotherapy, the immunotherapy, finally the ADT and chemotherapy, and my continuation on ADT together with reclass for osteopenia, osteoporosis at this point. But the essential thing for me, it was this idea of a partnership with my physician and Glenn in particular, to the point that I've always come back to him whenever anything new is going on or I hear about it. If he knows about it, we sit down and run through what the options, what the outcomes might be, and how it might fit. If he doesn't know about it, he goes and finds out about it and gets back to me. To talk about getting back to me, I mean, this is a guy, I don't think that's ever let a day pass on any question I've asked him over the last 15 years. So part of this is a long-term relationship. I mean, I've known him since day one of my post-prostatectomy, and I've continued with him. We've been afraid here in Wisconsin of losing some of our people from the UW because of the current politics of the state. George Wilding, for example, left to go down to, I think, MD Anderson. So we've got a little bit of a crazy thing here that's making me a little anxious about what the future is with the particular department. But the people who are still there, I've been entirely satisfied with. I felt a full partner with them in treating, this. It was almost like the two of us treating this third thing, like cancer. So it's been as good as I've expected, and I don't easily trust people. I mean, I take information in and I chew on it before I believe anything, and I'll get other input when I need it. This has been a fail-safe kind of thing for me so far, and I expect it to continue.
Yeah. Is Glenn a urologist, or did you say he's a?
He's a medical oncologist and a urologist. Yeah, he was. I ran into the urology department. It was one of those things where I was diagnosed by a urologist who also happened to be the surgeon who did the prostatectomy. Glenn was a urologist and medical oncologist, and so I was followed up by him out of the urology clinic.
Okay.
So,
and 15 years ago, the departments were somewhat differently administered, but that's how things go in a lot of these centers.
So,
Sure.
one of the things that I think is maybe worth talking about with the guys on the call right now is what doctor should you be seeing? With most people, it's pretty clear that you start off with a urologist or a radiologist.
Mm-hmm.
But in your case, it's a little different in that you know that your disease is already out the capsule. And the likelihood is that your quarterback is not going to be your urologist or your radiologist or your radiation oncologist. Your quarterback is going to be a medical oncologist. There's very good reason for you to have a medical oncologist on board very early on. Now, one of the problems with Mayo is that they really do not have very good medical oncologists. In fact, what's his face? Oh, I just lost his name. Who's the guy that does all the screening at Mayo? I heard him speak at PCRI. Somebody help me. Paul, who's the guy?
Is it Dr. Kwan?
Kwan, yeah, right, Gene Kwan. So Gene Kwan, has been known to send people out to medical oncologists in the area to get their chemo rather than use his own group. Kwan, were you scanned by Kwan?
I was scanned at Mayo.
Yeah,
I don't know.
Not under Kwan.
No.
His scanning. I forget what he uses. I think F18. I can't remember. Again, Paul Hobson may remember. But his scanning techniques are very, very good. But again, it's not really scanning. We know the issues with you. And what bothers me at Mayo is that you can go through all of this with Mayo, but when you're all done, if you need more treatment, you're going to have to find yourself a genitourinary medical oncologist, a GU medical oncologist, because that's the quarterback. If it were me, I would be wanting a GU medical oncologist to call the shots right from the off. And I would be talking with them as to what's the best way for me to be going forward. Surgery plus radiation plus hormone therapy. And, I think that given the glowing reference that John Streslek gives you, that maybe it makes a lot of sense for you to see Glenn Lou. And I'm sure, I don't want to put words into John's mouth, but I'm sure that John would be happy to, make an introduction and send Glenn a note and say, look, here's a guy that's really up against the wall having to make some decisions. Can you help him out pretty quickly and get you in to see him, pretty soon?
Sure,
and help you out.
Yeah.
And by the way,
that'd be awesome.
This is kind of what we do on this call. I mean, this is one of the benefits of this Answer Cancer, that we got people that are well connected in different places, and we'll always go to bat for somebody who's on the call, because we know that that somebody else will do the same thing for us. Let me throw it open. We've spent a good amount of time. We probably need to, since we've got more people on now. Anyway, but is there anybody that would like to add anything to give to Dan?
Yeah, Dan, this is Bill Franklin. I was 51 when I was diagnosed also. So I don't know what everybody else's ages were, but I know a lot of the people on the call were a little bit older than us when they got their initial diagnosis. And I know how you feel. I was thinking I'm too young for this.
Right.
But back to what Rick was just talking about, I was kind of lucky that in the fact that my my primary care physician is a family friend. She was a former flying student of my wife's. My wife's a flight instructor. So she's our primary care physician, and she sent me to the urologist. And after I was diagnosed by my urologist, in the practice was a surgeon. My urologist was a surgeon, but he didn't do robot surgery. So he sent me to another person in his practice. She did the prostatectomy, robot surgery, and also in their practice was a radiation oncologist, a genitourinary radiation oncologist. And I actually went to another, a medical oncologist, just to get another opinion, and because we're all walking around thinking, these people are telling us all this stuff. Who do I trust? Who do I know? So
right.
Had some other doctor friends, again, students of my wife's. A lot of doctors like to fly airplanes, and he recommended a friend of his, and I went to him, and it turned out that he and the radiation oncologist, the genitourinary radiation oncologist, were former partners that no longer worked in the same practice. But the fact that 3 of them were in the same practice, the other 2 were separate, but it was easy for me to let them know that I wanted all of my information shared with all of them, because my primary care doctor said, this is your team. So you don't have to go to one guy. And if you're not comfortable with the one guy you are going to, definitely, get a second opinion or go someplace else.
Right.
That would be my advice. Of course, I felt very lucky that I found this phone call, and I did get a ton of great advice from these people. So I think you're in the right place right now. Like Rick said, we can't give you medical advice, but we can tell you what we did and what we went through.
Yeah.
Yeah, that's awesome. What's your situation now, Bill? Are you?
I was diagnosed in late 2015, and got a radical prostatectomy. And like I said earlier, they didn't get it all. It came back, and I went through radiation treatment. Been on ADT for about a year now, and my PSA is 0. My last bone scan was clear, and my doctors just want to keep me on ADT for 6 more months, and then see what happens after that. But at Rick's urging and my own personal feelings, I've been really exercising a lot, working out, and that's really helped on the ADT. So I don't know your situation on the ADT. If you've been on it since May or earlier in the year?
Yeah, since May. And the side effects obviously was, I lost the erectile function, but other than that, I'm fine. I'm working out quite a bit too, running 3 to 5 miles, 4 or 5 days a week.
That's
some weightlifting.
Yeah, that's great. That's really important.
Yeah.
It's really important. And let me just say one thing about the erectile issue, which is that what the hormone therapy does is it takes your libido away. It doesn't stop the function, but you don't have the desire. And for some men, they still they don't lose all their libido. Some men do lose all their libido. It's a very it's not exactly clear. And there are things that can be done, and that it's a good discussion to have with your doctor as to what you can be doing in that regard to maintain erectile function whilst you're on the therapy. But it's really more a psychological than a physiological issue with the lack of testosterone. I just want to mention a couple of things to you, Dan, because we have two other calls. Right now we're running 10 calls a month, which I'm hoping is going to keep expanding, but we have two other calls that may be of interest to you. We have a call twice a month called the Inner Conversation, which is a men-only call, and it's moderated by John Teisberg. And it's really more of a sort of a men's group call, but you get to talk about issues around erectile dysfunction, around the role of your caregiver, how this is affecting your family. It's not technical or as technical as this call is. There's an element. I mean, Jake, do you want to maybe, since you frequent that call a lot more than I do, do you want to just give the group a little feel, do a little promo for John's Inner Conversations call?
Sure. I think this is the second and fourth Thursday of every month at 8 o'clock. It's basically just a bunch of guys, only guys, and right now it's only people with prostate cancer. And we just, we usually come up with a topic, what do you want to talk about tonight? And we stick to that topic. One topic was, how do you feel about having prostate cancer? Another one was, how does your family react, and how do you deal with that? It's like Rick said, it's not technical. There's very little medical advice given, but it's just people who are in the same boat, and we just kind of compare notes and kid around. Sometimes the talk gets a little salty, but it's wide open and it's kind of fun, and I recommend it. It's usually I feel better after I've logged on.
So that's one call, and then the other call might be for Karen. We have a caregivers call, which are for caregivers only, and that it's just really to sort of help them in how to deal with these issues. And I'm sure this is. Do you have kids, by the way, Dan?
Yeah, 3 kids. Yep.
So she's dealing with a lot, and I'm sure she's very supportive to you. But we sometimes forget that the caregivers themselves need supporting as well. And we run a caregivers call on second and fourth Tuesday. No, excuse me, first and third Tuesdays. One is at 1 p.m. Eastern, and the other is at 6 p.m. Eastern, because we're not really sure when people can sign on. But all of this information is on our website, which is ancan.org, ancan.org, ancan.org. And you can also write to me. You have my address, and I can, send you the information. You can call me, but both those calls may be helpful to you and to Karen, and that's what we're here for. And I will, as soon as we're done with this call, I'll send an email to you and to John Streslek. So I don't have your telephone numbers, but I have your emails. So I will send you emails, and then you guys can exchange telephone numbers. You can talk, and you can figure out how best to get yourself in for for another opinion in Madison.
Yeah, that'd
be great.
Yeah, that sounds good.
Okay.
Look forward to it. Yep.
Okay. So we're going to move on. This this is really a benefit of not having too many people on the call, because we've been able to take a lot of well-deserved time. And, you know, sometimes I was saying to Dan before when he first called on, we had a slow start, and there's sometimes a benefit from having fewer rather than more people on the call. So let me just go down the list and see if there's anyone else that's joined us. Right now I have Jake Hannum, Bill Franklin, Dan Schulis, Sylvester, Sherry, and John Streslek, Paul Hobson, Paul Frieda, Eric Bookbinder. Is there anybody else on the call? Okay. So let me run down the list and see who would like some time tonight. Jake, anything for you?
No, Rick, I don't have anything tonight.
Okay. Bill Franklin, how about yourself?
No, I'm good, Rick.
Okay. Sylvester, how about you?
Not tonight. I'm just glad to be listening to the discussion. Thanks so very much.
Okay. Paul, Sherry, and John, anything for either of you?
Maybe just for you, Dan, I always take a book, a binder to my appointments when I go with John to see Glenn Liu. And I have written little notes from Us to Inspire, the website. And I have actually, then I bring it up to him, like Dr. Kwan at Mayo Clinic does a choline C11 injection, PET scan, da-da-da. He always has an intelligent answer for everything that I bring up, which makes me know or feel confident about him being in the loop of this disease, with this disease.
Yeah.
That's probably what I didn't mention is that Sherry has the same kind of confidence in Glenn that I do, and that's important. That the two of us are always on the same page when we before we go into the appointments and after we come out of it, and when treatment decisions have been made. And to be honest with you, I just didn't expect that kind of collaboration. It's really been good.
Yeah, that's great.
Yeah,
Okay.
It has been. Yep.
Good to know.
Not that having disease is great, but this whole stuff is, I think, as good as it can be. I've been lucky. Yeah.
Does does Karen attend your appointments with you, Dan?
Yes. Yep. She does.
Okay. Okay. Let me just keep going down. Paul Hobson, how about yourself? Anything for you tonight? Are you still with us, Paul? Oh, he may have stepped away. Yeah, there you are.
I'm madly pressing buttons.
That's
so
okay.
Nothing.
You want to
give
us a little update on where you are with your how you're progressing for your lutetium trial? You can do that. Nobody wants to talk tonight, so maybe you can just tell us how you did, and because last time you were doing that kidney function test. We'll come back to you in a minute. Let me just.
No, I'll quickly just. The situation is I've done all the testing, which a couple of PET scans. One is the PSMA PET scan. Another one is a fluoride glucose one. They're wanting, one of the things they want to see is that there's good PSMA expression from the tumour, and that they can see what they're targeting. The other thing is that they're wanting to match where the results they get from the PSMA PET with the FDG PET that they want to be targeted. They want to see that the prostate cancer cells and the areas of activity shown by the FDG thing coincide. Kidney function test was okay. Had CT and bone scans. I'm now just waiting till they give me the lutetium infusion, which is going to be on December the 8th.
Oh, so they have determined that you have sufficient PSMA, and they've admitted you to the trial.
Yes, that's correct.
Oh, good. Okay. Oh, excellent, excellent. And how many lutetium infusions do you get?
What they're going to do is 4 infusions on a 6-weekly basis.
Mm-hmm.
But in some cases, they've had very good results after 2 and have stopped people after 2 and possibly go back later on.
Mm-hmm. Let me, if I may, let me come back to you because I want to open this up for other people, but I just want to check and see, first of all, if Paul Frieder and Eric Bookbinder have need any time. Paul, would you like to talk about anything tonight?
No, I'm good.
Paul Hobson, could I just indicate I've got to go about on the half hour.
Oh, okay. All right. Okay. Well, yeah, no,
25 minutes.
We'll come back to you because nobody wants to talk. And Eric, do you have anything that you'd like to talk about tonight?
Well, I could, give my status of my study.
Okay.
And
all right, we'll come back to you. Yeah, we'll definitely come back. So let's just go back to Paul Hobson because, Paul, I'm sure that there are people on this call who, we're talking about PSMA and lutetium and this is, it's all a foreign language to them. So would you mind just giving a quick primer to people that aren't familiar with this test that you're doing and I will also add, by the way, it's not available in the United States just yet, but they're working on it. But Paul, can you talk a little bit about this lutetium PSMA test?
Well, possibly first of all is the PSMA. What they've found is that prostate cancer expresses a protein called prostate-specific membrane antigen, PSMA, and this protein sits on the outside of the prostate cancer cells. Pretty much there are some other areas in the body that do express PSMA. For example, the salivary glands express PSMA. I think there's also some in the kidneys, but the amount of PSMA expressed in other parts of the body is very minimal compared with what comes out of the prostate. So the situation is you've got this PSMA protein sitting on the outside of prostate cancer cells. They're now able to target the PSMA antigen on imaging using a gallium-68 isotope, so that there's a gallium PSMA PET scan where they're able to target this protein that sits on the outside of the prostate cancer cells. That they can get quite good results from very low levels of PSA. So that even as low as 0.2 PSA level, you can get things showing up on a PSMA PET scan. The accuracy at the very low levels of PSA is not as good as it gets higher. My first PSMA PET scan that I had a couple of years ago, I had it when my PSA level was 0.7, and that scan showed up spots, cancer sites that weren't showing up on an ordinary CT or bone scan. or on the other PET scans. So that they're using the PSMA protein for imaging to show where the cancer is. And you can get it much earlier than by using the other types of PET scans. What they're now doing, and they first started in Germany and Holland, but in Australia we've now got this clinical trial going on of 20 people. When they target the PSMA, which sits on the outside of the prostate cancer cells, they're now adding into the nanoparticle that they're using to target the cancer cells. They're adding in a radioactive isotope, and the one that they're using at the moment is lutetium. And what happens is that because it's finely targeted, they're able to get the radioactive isotope sitting right up against the outside of the prostate cancer cell. And the lutetium emits fairly low impact radioactive waves, so that the radioactivity gets the prostate cancer but has very little effect on the surrounding healthy cells. So that's basically the idea. They're playing around with various types of isotopes. They're looking at possibly using a copper one instead of lutetium. So far the results have been getting quite good results, but they can get quite, in some cases they've got very good remission, but it comes back after 15, 18 months. Also because there are micromets floating around elsewhere that they don't pick up. Also, they're not certain on the long-term toxicity, so they're not certain once you've had your 4 or your 6 lots of lutetium whether when the thing comes back you can start off and have it all again. They've almost, I'm probably the last person, I'm probably number 20 on this pilot study that they're doing, and they're hoping to do a much larger study next year, which I think is also looking at international sites. I hope that's been a fairly simple explanation, but it's just,
terrific.
You know, what they're doing is quite amazing.
Yeah, and what I'd like to add is that some of you listening, you may say, well, you know, this sounds like Xofigo, radium-223. Well, in a certain sense, it is the same type of science, technology, if you like, but the big difference is that radium-223 is sensitized to be attracted to calcium, and we have lots of calcium in lots of different places in our body, and so when you get a Xofigo shot, that radiation doesn't just go to the bone spots where there's metastasis. It goes to a whole lot of other places, and it can do a lot of damage, and particularly it can suppress the bone marrow. So unless you have very healthy bone marrow going in, you run the risk of myelosuppression and you know, driving your bone marrow, driving your blood counts down to very low levels. So what's the beauty of the PSMA is that it's finely targeted to prostate cancer cells wherever they may be in the body. So they may be in the prostate, but you may have a metastasis somewhere, and that metastasis is clearly expressing PSMA, and so this lutetium is getting attracted there. So there's a lot of interest in this PSMA science, and there are several of the institutions around the country that are running trials, but for various reasons, which I'm not totally clear on, it has not yet been approved for wider use. I mean, I understand why it doesn't have FDA approval. What I don't fully understand is why lutetium isn't available in this country, but it is overseas. And for some reason, then we're restricted. Does anybody on the call have questions for Paul?
Could I just come in? Could
Yes.
I just come in again?
Yep.
On that point of lutetium compared with radium-223.
Yep.
Radium-223, as you said, goes for the calcium. The lutetium goes for the prostate cancer cells wherever they are, so that lutetium can do attack metastases which are in the lymph nodes and in soft tissue sites which radium-223 can't.
Yeah. Would anybody like to ask questions about this lutetium science and the PSMA?
Where are they doing that trial?
In Melbourne, Australia.
Okay.
Now,
the earlier trial was done in Germany.
Go ahead, Eric.
Are there other trials? Oh, are there other trials?
There are other PSMA trials that are going on, not with lutetium. The UCSF has got a trial going on with gallium-68, but I think it's only a scanning trial. I think it's not a curative or palliative type of trial, I believe. But the trial is being run by Albert Chang and Tom Hope. But I'm not 100% sure if they've got any trials going on, PSMA trials going on for palliative and curative.
I think at the moment most of the things going on in the States are relating to the imaging, not so much them using the imaging to target.
Yeah. Eric, go ahead.
I was going to say that I participated in that imaging study.
Right.
So.
Right. And how effective was it for you?
They were pretty close-mouthed about the results. The Dr. Whatever his name is, Agarwal. Agarwal, that's it. Dr. Agarwal said that it showed pretty much the same thing as the other scans. That it was stable and that the trial drug I'm on is keeping the cancer stable. So they did a study about a month before I started the trial drug and after two months of being on it. So not too definitive, but at least encouraging.
Anyone else? Would anybody else like to talk to Paul about this trial and this technology before he leaves us?
I have a question. This is Jake.
Go ahead.
You answered my question about the difference between radium and lutetium. It sounds very promising, the fact that it attacks all cancer sites, regardless of whether it's in the bone or not. So that's assuring or reassuring. But my question to Paul is it a systemic infusion, or do they give injections near the sites of where the cancer is?
It's a systemic infusion.
Okay, but the lutetium itself only goes to the is attracted to this cancer cells only. Does not affect the rest of your body.
Well, subject to some of the other areas that have small uptake of lutetium, such as the salivary glands. it only goes to where there's the prostate cancer.
Right. So in other words, Jake, it's attracted to PSMA, prostate-specific membrane antigen, which is largely on the prostate cells, but for some reason also expresses itself on certain other organs like the salivary glands and maybe a couple of other places.
Prostate cells or prostate cancer cells?
Prostate cancer cells.
Okay.
Well, I thought it was prostate cells, actually. I think it's prostate cell. I think the prostate-specific membrane antigen shows up on prostate cells. Now, prostate cells, when they spread outside the prostate, are prostate cancer cells.
Right.
By nature. You know, that's what they are, and that they're prostate cells that are out of control and growing in places where they shouldn't be growing. But the PSMA will appear even on in healthy prostate cells. Somebody who doesn't have prostate cancer but has a prostate, they're going to express PSMA.
Oh. Okay, well, thank you.
Paul here, could I just add in one thing?
Sure.
This sort of radionuclide treatment has been going on for about 20 years in different places around the world in relation to neuroendocrine tumours, fairly rare tumours. And one of the although it's a widely practiced technique, just the limited number of rare cancers and the small number of patients has meant that they haven't been able to get extensive clinical trial results on the technique. But the nuclear medicine people, now that they've got a large cancer group like prostate cancer, are almost rubbing their hands that they can get these results indicated by clinical trials. So it's not a new idea, but it is a new idea to prostate cancer.
Any other questions, or any other people would like to discuss this technology? Okay, we'll Paul.
I'll tell you in a fortnight or 3 weeks.
Yeah. I mean, so your when did you say your first infusion is?
The 8th of December.
Okay, well, we'll be thinking about you, and we'll be talking with you, and you'll update us, and then how soon after you start will they scan you? I mean, how do they determine if there's progress or not?
What they do with the scanning, on the day I get the infusion, they'll do further scans on that day to look at how the uptake is going. I'm not sure what it's, say, 3 hours, 4 hours, 5 hours afterwards. I'm then back for a scan the following day to see what's happened 24 hours later. And then on day 4 or 5, I'm back for another scan. So quite a lot of scans at various time periods after each infusion. So each time I go through and have an infusion, we'll be getting those types of scans done.
Well,
yeah, it sounds like they're doing the scans basically as part of the test, just to know how it's being, like, the uptake, like you said. But hopefully, if it ever becomes common practice, hopefully you won't need that many scans, and hopefully you'll be able to measure PSA or something to know whether or not it's working.
Sure, yeah, but with a clinical trial there,
Yeah.
sort of monitoring everything which way type of thing.
And just out of curiosity, what is your starting PSA?
Don't know is the answer to that. The latest I'm waiting on some blood test results to come back. The last the last PSA I had about a month ago was 150. So I'd expect my current PSA is 250, 300 type of thing. But,
okay.
that's my informed guesstimate, and I'll wait. I'll find out when I go in for the infusion what current PSA levels are.
Okay. Okay.
But
Well, thank you.
We've had guys who are much higher. One chap I know who's on the trial, I think, had PSA of over 1,000 when he started, and he's now, I think, after 3 infusions down to single-digit PSA.
Wow. Excellent.
Yeah, that's great. Good luck, Paul. Let us know how it goes.
Yeah.
Yeah, no, the sooner that, I think one of the problems with it is that with certainly the gallium, there are issues about patents, that there's no benefit to large drug companies because they can't get ownership of the technology. There's a reluctance to get involved.
Yeah. That's absolutely right. That is one of the issues. Thank you for reminding me. Yeah.
Whereas
anyway,
in sort of Europe or Australia, where there's more socialised medicine, you can get public institutions doing the trials.
Right. Okay, well, thank you again, and a great contribution today, Paul. We really appreciate it. And by the way, guys, you know, we do record these sessions, and we post them on our website on ancan.org, and they're also on our YouTube channel. So you can go back and you can listen to this again if you missed anything. Hopefully it'll be posted by the end of the night tonight. So thanks a lot. Eric, why don't you tell us where you're at and how you're doing on your trial?
So there was a 3-month initial session of this trial, and at the end of the 3 months, I had some scans, and as I say, it showed that it seems to be held in check. So I started on another 3-month round of medication. I'm hoping also to get on an immunotherapy trial. My worry about that is they probably won't want me to stay on the other drug, and if the immunotherapy doesn't work and then I'm not on another control drug, then the cancer may just start growing again. So it's taking a chance to do it. Apparently there are several studies that will be opening up either next month or this month, and they said they would keep me in mind for those, so I'll have to keep reminding them. They haven't been overly responsive when I've been trying to get information and get schedules, and so it's less personal than I thought it would be. There are certain individuals that are very concerned personally and show concern, but I don't know, maybe they're just also overworked that they don't have really time to spend. I don't know.
I mean, look, I want to come back to the trial a little bit, and the drug that Eric is trialing is something called GS5829. It's made by Gilead, and we'll come back to that in a second. But I just want to address a little bit this navigation problem at UCSF, Eric. Are you still with Amy Lynn?
I haven't seen her in 6 months or more.
Okay. So do you have a quarterback in terms of a doctor that you feel is like running your case? Is it Agarwal, or who do you
Yeah, it would
think?
have to be. Agarwal would be the closest that I have in that respect.
Mm-hmm. And
yeah, I didn't get a lot. I mean, my first visit with Dr. Lynn was, I felt positive about her. But the second one, it was kind of like, her mind was somewhere else, and
right.
she needed me to finish up and get out of there. So,
right.
Right.
I would not recommend Dr. Lynn to anybody after the experience with Trevor, God rest his soul. I'm sure she's a very good doctor, but I also feel that she just, she blew it, and she had plenty of opportunity. And I attended the appointments with Trevor, and I asked for her to do certain things which she didn't do, and by the time she got around to doing it, it was too late. So whilst I have, as you know, an exceptionally high regard for the genitourinary group at UCSF, she's probably the one doctor that from my own personal experience, I would tell people to avoid. And I think that in your case, I don't know whether Agarwal feels ownership for your case, or whether you're sort of, that may be the problem, that you're dropping between the cracks between Lynn and Agarwal. And
well,
I think,
and my Berkeley oncologist,
and your
who now
Berkeley
has sort of said,
oncologist.
oh well, now you're with UCSF, so I don't have to do much.
Exactly. And I think that it probably warrants a discussion with Agarwal, that if you like him, I mean, if you feel he's too busy, it may be because he doesn't figure that you're his patient.
Mm-hmm.
And that if you were his patient, you might get a different response. I'm not saying you will, but you might get a different response. But I think that what you need is a responsive go-to doctor, medical oncologist, GU MedOnc at UCSF, and you don't seem to have one at this point in time, and you need to get one. And we can talk about how to do it, but the starting point is to go to Agarwal and see if he'll take you on if you want him. If not, I'll give you some other names.
Okay, yeah, I have an appointment on the 5th, so it's coming up soon, and I'll query, everyone I get around and see if I can push to get somebody in charge.
Has anybody else on this call experienced something similar where, in a sense, it's sort of the opposite to what John Streslek is finding, where he's got a Dr. Lou who really is his go-to guy and gets everything coordinated. And I've seen that happen also, by the way, at UCSF. There's some very good doctors there. But is there anybody who feels that sort of there are too many cooks in their treatment, and how have they resolved that? No one? No one wants to comment on that?
Yeah. I'm more interested in the situation where I think you mentioned that was talking to a doctor at Berkeley, and then they found out he went to UCSF and then didn't really want to talk to him. That's something that I'm running into, where I am talking to a lot of different doctors, and I'm afraid to the doctor that I'm talking to, I'm afraid to tell him I'm talking to other doctors because they seem to take offense to that. and kind of write you off, you know. I mean, it's like Mayo. I'm at Mayo. I'm afraid to tell him I'm talking to the doctors and vice versa because you just feel like they got such egos that then they don't want to talk to you anymore. I don't know.
Yeah, Dan, I mean, I think you're raising a really good issue. Anyone else want to contribute on that point?
This is Eric. My doctor in Berkeley is, she hasn't just, you know, removed herself from the picture. And probably if I push her more, she'll be more active. She did have some trials that she was working on, and you know, I think maybe she was, you know, was hoping I would go with those rather than the ones at UCSF. But she didn't really have any objection, and they do work somewhat closely together. So you know, I've had this shortness of breath problem, and she has me. You know, I have a cardiologist who I'm right now wearing a heart monitor, and I'll be wearing that for 2 weeks, and then I'll have a stress test, and the heart monitor has a little button on it that I push whenever I have a stress situation, and then I have a little app here on my iPhone that I fill out the time and all the details about. So they will coordinate the two afterwards and see if there is any relationship between the shortness of breath and something with the heart. So,
now, is that all at Outer Bates, or is that at UCSF and Outer Bates together? Are they coordinating on that?
They are not coordinating. It's all Outer Bates.
Okay.
I go out. The cardiologist is out in Pill Hill, and that's, you know, that is being done through there. As a matter of fact, the cardiologist wanted to see my EKGs, and every time I go to UCSF, they take at least 2, if not more, and you know, there's the Epic system where they can coordinate their data, but they don't put that into the Epic system. So she had to do one in the office because she had no reference. You know, I don't know why they put it in there. It's sort of bizarre. They we know when I'm scheduled at UCSF, I always, you know, I do labs, I do an EKG, I see one of the doctors, and then I get my next set of treatments, and I have to push them to get them to set up the appointments, and you know, they have an online system, so I can look at my appointments, but the labs don't show up online, and they say the reason the labs don't show up online is that they're drop-in. Well, okay, that's fine, except where's the reminder to go to the lab? You know, I have to make my own reminders, and you know, I have to go to the lab before I do the other one, so I have to go early enough that they can get the results. So, you know, I don't see any purpose in, you know, they could just say at the beginning, general lab appointment, but no, they don't put that in the computer.
Somebody else wanted to contribute on the issue around managing doctors. Go ahead.
This is Bill. I was just going to say that again, I feel pretty lucky with the team that I have, but I was always a strong advocate for myself. If I felt like 2 doctors were giving me, you know, conflicting information, I made it very clear that whoever's treating me right now is the guy I want to listen to. So during radiation treatment, you know, my urologist had made an appointment for something, and I didn't even understand why he wanted to see me. I was in the middle of radiation, being treated by the radiation oncologist. So, you know, some people would go and try and find out what he wanted, but I just called and said, unless you can give me a good reason to come there, I'm not coming. So,
you know,
but I made it very clear to all my doctors that, you know, you're the one treating me right now. I'm listening to you, but they were all a good group. They work well together, and I'm very lucky, I think.
Yeah, I mean, I think Dan's situation is a little different in that he hasn't really signed on with anybody yet, and so the concern is that everybody wants ownership of the patient, and Dan hasn't decided who to give that ownership to, and it's better if people talk to each other. I think within an institution you're going to find that is likely to happen. So, for example, if you go make an appointment at University of Wisconsin, the doctors within University of Wisconsin are going to huddle together to try and help you decide what sort of cooperation you're going to get between, say, Mayo and Wisconsin in terms of deciding a treatment path. I doubt very much at all. First of all, because they have very different attitudes in how they treat the disease. And I think one thing you've got to look very carefully at Mayo is what expertise do they have at Mayo? They certainly have surgical expertise, but do they have the radiation oncology expertise? Do they have the medical oncology expertise for prostate, specifically for prostate cancer? Because I think it's important that when you do decide where you want to go, that you have all of the different specialties available to you. Even in that situation, you could run into the type of problems that Eric's having, but those problems are relatively unusual within the same institution. They happen, as we hear, but largely because there isn't somebody who's really carrying the flag, the banner for Eric, and that's really what I want to try and see if we can create, so that there's some leadership. There are some super fine doctors at UCSF who will assume and take that ownership, and we've got to try and get Eric to one of those docs. Anybody else want to talk anything more about this situation? If not, maybe Eric can just tell us a little bit about this trial for those of you who are interested.
Well, the drug is a BET inhibitor, and it acts something like Casodex and those drugs, in that it prevents the cells from taking up testosterone. Apparently, this is supposed to be much more effective. That's what they're hoping, and so far it's working for me. Although my PSA has not gone down, but it's it went up, up in the what's high for me, 6, 7, 8 area, and it's staying there. So, but the scans show that the cancer is not growing, so that's what I'd want. At the end of 3 months, I asked about what happens when the study's over, and they said that I could stay on the drug as long as it's being effective. So there's no termination. There's no set termination date as long as it keeps working.
Mm-hmm.
Although the usual, like Casodex and those other drugs,
right,
it will probably have a limited time that it will work, and then we'll have to move on to something else anyway.
I mean, Eric, there's something to be said for squeezing the last drop out of the treatment, and then going on to the immunotherapy treatment after that. And you've done, I can't remember, you've done Provenge, haven't you?
No, I have not done Provenge.
You have not done Provenge. Well, I mean, I think that's probably a discussion. I mean, I don't know why you couldn't do Provenge at the same time as this drug. You're certainly a candidate for Provenge. And, that's the discussion you should be having with your quarterback doctor, and you don't have one. We're back again. But, on this discussion with Ragawul, where you try to create your quarterback doctor, I would be talking to him about getting Provenge in now because, you know, one of the issues with Provenge is that when the tumor burden gets too high, they won't give it to you. And the way that Larry Fong is was the principal investigator for Provenge. And the way he explained it to me one time was that when there is too much tumor burden, then the dendritic cells that are infused into your white blood cells, that these treated cells that are given back to you, they don't have a big enough landing strip in order to be effective. The immune system's so busy fighting where it needs to fight that there's no place for the cells to come in, to embed, and then to start working. So it's better to get Provenge earlier rather than later in the disease. And I think that's a discussion. I mean, it's an approved treatment that you might want to be considering right now.
Okay, I'll bring it up.
Bring it up. Okay. So I think we've been through everybody. I don't think we have anybody new on the call. This rarely happens, but it's quite a pleasure because we've had plenty of time to dig in with everybody. Is there anyone who would like to raise anything right now? Talk about it whilst we've got the group together. Well, if not, maybe we'll even finish early today. There's something new. We could finish 15 minutes early. That's great. But you know, again, what happens?
I do have a question.
Yes. Go ahead.
About your caretaker meeting.
Yes.
When is the next one of those, and how are you recruiting people for it?
Okay. So our next caretaker meeting is, I believe, December 6th, the first Tuesday in December. Let me just check that. December 6th, right. It's going to be December 6th at 6 p.m. Eastern, 3 p.m. Pacific, and everything in between wherever you are in the country. How are we recruiting? Well, we have a list that we send out to of about, I don't know how many names Renata has on that list right now. And then we post the Caregivers session on several forums on Inspire. So we posted on the prostate forum, we posted on the breast cancer forum, a lung cancer forum, a colorectal forum, brain, and a couple of others, I think. Now, tomorrow I have a call with the Boniadario Foundation, who are one of the major lung cancer foundations in the country. And we're going to be telling them about it, so they will probably put out the word. We're talking to them largely about starting a lung cancer call, but the caregivers call is open to caregivers for all stage 3 and stage 4 cancers. So that's what we're doing, and we're open to suggestions. If you have any other ideas as to how we should market it, tell us. We'll follow through, or we'll get you to follow through for us.
Did you say it was 6 or 7, Rick?
It's 6 o'clock.
You said 6. It's according to the ANCAN.
7. Excuse me. You're right. Yeah. 7 o'clock Eastern. Forgive me. 7 o'clock Eastern. Thanks for correcting me. 7 o'clock Eastern, and then the other call is at 1 o'clock Eastern. But yeah, so it's at 7 p.m. Eastern, 6 p.m. Central. So if Sherry or Karen want to join us, it's at 6 p.m. Central, 5 p.m. Mountain, and 4 p.m. for me. So does that answer your question, Mr. Bookbinder? Good. Okay.
I have a
Yes.
brief comment that,
Yes.
that might be helpful.
Yes.
We in the past we've discussed the ARV7 variant and the issues with people taking enzalutamide and
Yes.
abiraterone.
Yes.
Well, Antonakis posted an article today, or that I saw today, about a test that might give, a trial that might give hope to people who have that variant, that says they would not be good subjects for those two drugs. And it's, the trial is just basically they're giving monthly testosterone shots, and they think that sensitizes
Right.
whatever. So I can give you a link if anybody's interested, but I thought it was,
Yeah.
he mentions several other trials, but
we're actually pretty familiar with that. It's called bipolar testosterone, and it's being conducted at University of Washington, the Seattle Cancer Center at University of Washington, and at Johns Hopkins. Together they're working on this. It's Antonakis, and I'm just blanking on the name of the guy at UW, but I've got it now. Frank Kelly, who sometimes is on this call, but now he's more often on your Inner Conversations call, is actually following the exact same protocol.
right.
And
But
I
don't think that was specifically about the ARV7. That was just a trial. This is specifically for the ARV7 people to somehow or another resensitize or remove that wild type variant or something.
Well, that's right, but that's the whole issue of the. I mean, remember that Frank was one of the guys that failed enzalutamide and failed abiraterone.
Right.
So most likely he was ARV7 positive.
Okay, you're right.
Right. So so if you're ARV7 positive, this this bipolar, and what it is, gents, I mean, Jake described it very well. It's basically giving you very high doses of testosterone for 3 weeks or so, and then taking you off of it. And the idea is, the theory is that it will resensitize the androgen receptors and allow them to respond to some of the second line drugs. I know that Thibault Lincecum is also considering that trial as well, if he once he moves on from the trial that he's on right now. But thanks for bringing that up.
Welcome, no problem.
Okay, well, we're inching towards 5 o'clock my time, and whatever it is across the country. But thanks everybody. Do take a look at the website ancan.org if you haven't. I also want to give some public thanks to Jake, because he has very, very kindly agreed to be our webmaster for Facebook, and we will soon be having a Facebook presence and a Twitter presence. And some of this is learning on the job, but he's doing a great job, and we're
a lot of it's learning on the job.
Okay, but I'm not a Facebook person, and so I had to pull someone else in. But we'll be sure everybody knows once we're there. And we're also going to be doing an end of year fundraising, and you'll be seeing that letter coming out probably next week sometime. So we got a lot going on. Okay. Thanks, everybody, and good night.
Thank you, Rick. Good night, everybody.
Thanks, everyone.